Welcome back to another deep dive. If you're joining us for the first time, or, if you've been listening for years, we are just thrilled to have you here.
Yeah, absolutely. It's great to be here.
So, usually when we talk about getting a medical diagnosis, there's this expectation of, I don't know, almost engineering level precision.
Right.
Like you break your arm, the x-ray shows that jagged white line on the glowing screen, and the doctor just points at it and says, there's the fracture.
It's very binary. It's either broken or it's not broken. And that kind of visibility is comforting because we fundamentally just like things to be neatly categorized.
Right, exactly. But then you step into the world of human behavior, and suddenly that x-ray machine is totally useless. We are looking
Yeah.
at a diagnostic landscape that is, well, incredibly murky.
Yeah, it's the definition of diagnostic muddy waters.
Hmm.
I mean, when a person is engaging in some complex, challenging behavior, you can't just scan their environment and instantly see the fracture. It doesn't work like that.
Which is actually a perfect bridge to today's deep dive. We're looking at a stack of sources today that include official mock exams, study guides, and some incredibly detailed ethical case workbooks used by professionals in ABA or applied behavior analysis.
Really heavy material in there.
Oh, definitely. And for you listening, our mission today is to explore this foundational concept known as BCBA Foundation's F.1.
Right, the intake process.
Exactly. It's the mandate for a board-certified behavior analyst to conduct a comprehensive records review at the very beginning of a case. We're going to figure out why digging through, stacks of dusty old paperwork is actually the ultimate shortcut to effective behavior analysis.
And how it prevents some pretty dangerous misdiagnoses, too.
Yes, and why it absolutely must be the first step before any observation even begins.
Because reading old files, it sounds like a purely administrative chore, right?
That sounds super dry.
Yeah, it does. But the documentation in our stack reveals that this is actually a really high-stakes detective investigation.
Okay, let's unpack this. Let's start with the golden rule of intake. So we're looking at this F.1 directive from the Behavior Analyst Certification Board, and it states that professionals must identify relevant sources of information in records, things like educational, medical, and historical data at the outset of the case.
And those words, at the outset, they carry a lot of weight.
They really do.
Before professional attempts to alter a behavior, they are strictly required to understand its history. They're hunting for very specific documents.
Like what? What are they looking for?
Well, they want individualized education programs, or IEPs, which are essentially roadmaps of a student's past learning goals. They want previous functional behavior assessments to see why a behavior might be happening. And they definitely want narrative reports from speech therapists or classroom teachers.
Yeah, and I noticed the mock exams in our sources also make a huge point of testing what is irrelevant.
Oh, the distractors.
Right. There's this one scenario where an analyst is starting a new case, and the multiple choice options for what to review include the medical files, the educational history, and then random things like a family's financial records or a client's birth certificate, which, the financial records are obviously a distractor.
Yeah, they're a distractor because the goal is mining for data that establishes clinical direction.
Yeah.
Not just, satisfying your own curiosity. The analyst is looking for past target behaviors, the environmental triggers that maybe contributed to those behaviors, and crucially, what interventions have actually already been attempted.
Okay, I have to challenge that approach, though.
Sure.
If I think about this like a detective opening a cold case file before visiting a crime scene, isn't there a massive risk of bias?
How do you mean?
Well, like, a frustrated past teacher might just write in the file, this kid is just manipulative and lazy. How does an analyst read that and still go in with a fresh set of eyes? Doesn't reading all those old opinions kind of poison the well?
What's fascinating here is how the guidelines address that exact tension. Because a fresh perspective is highly valued, of course, and the analyst will eventually do their own direct observation. But going in blind is considered a complete breach of professional standards.
Holy, a breach.
Yes, absolutely. So, to counter the bias you mentioned, the analyst is trained to extract objective data from subjective notes. They completely ignore the label manipulative, and instead they look at the hard data.
Like the frequency of the behavior.
Exactly. How many times did the behavior occur? How long did it last? And most importantly, what happened immediately before and after it?
So they're essentially panning for gold in a river of opinions.
That is a great way to visualize it. And, ignoring that history can lead to some really serious consequences. Our sources highlight a specific scenario involving an analyst. Let's just call her Annalise for this.
Okay.
She took over an ongoing case because her colleague was just completely overwhelmed.
Oh, I remember this one from the case workbooks. She decided to skip the file review, didn't she?
She completely bypassed the records. She already had another client with a seemingly identical problem, so she simply copied and pasted that existing behavioral plan for the new client.
Wow. Just copy-paste therapy.
Yeah, and this violates the core standard regarding case conceptualization. By skipping the historical data, she failed to individualize the assessment. Reviewing past records shows a professional what actually worked for this specific person, and perhaps more importantly, what failed miserably.
So you don't repeat the trauma.
Right, it prevents the client from enduring a useless or highly distressing intervention for a second time.
You aren't reading the old files to copy their answers. You are reading them so you don't repeat their mistakes.
Exactly, you are establishing a baseline of truth.
So we use this paperwork to establish that baseline and protect the client from repetitive, failed interventions. Here's where it gets really interesting, because we have to look at the medical rule-out. According to our stack of sources, the absolute biggest mistake a behavior analyst can make is treating a biological problem with a behavioral solution.
Oh, this is a cornerstone of the field. The guidelines specifically dictate that if there is any reasonable likelihood, any at all, that a behavior is influenced by medical or biological variables, the analyst must consult a medical professional.
Because they aren't doctors.
Right. Behavior analysts are experts in the environment and learning, but they are not medical doctors.
The case studies in the workbook bring this to life in just a terrifying way. There's this dramatic scenario with a young child exhibiting severe self-injurious behavior. We are talking about intense headbanging and severe biting.
Very scary stuff.
Yeah, the kind of alarming situation where a school team or a family might panic and demand that the analyst just immediately implement behavioral interventions to make it stop.
And the pressure to act in those moments, I mean, it's immense. Everyone's looking at you to fix it.
Yeah.
But in this case, the behavior analyst hit the brakes. Before drafting a single behavioral plan, they insisted on a comprehensive medical review.
Which probably felt like a massive delay to the family, but the medical tests revealed that the child had bleeding ulcers.
The child was in excruciating physical pain. They were not engaging in self-injury to gain attention or, to escape a difficult math worksheet. It was biological distress signal.
Right.
Consider the alternative here. What if the analyst had just assumed it was a learned behavior? They might have put the child on a behavioral protocol, or worse, an extinction procedure.
Wait, extinction, let's clarify that for a second. Is that when you just completely stop reacting to a behavior so it eventually dies out?
Basically, yes. That's the mechanism of extinction. You remove the reinforcement that usually follows the behavior. So if a child screams for candy and the parent stops giving candy, the screaming eventually stops because it doesn't work anymore.
Okay, I see.
But applying an extinction procedure to a child with bleeding ulcers, that means you are intentionally ignoring a child who is suffering from severe internal trauma.
That would be literal torture.
It would be catastrophic. And once those ulcers were treated by a physician, the underlying pain vanished. Only after the biology was addressed could the team safely proceed with a functional assessment to see if any residual learned habits remained. Biology always dictates the first move.
Always. And the study guides highlight another, perhaps more everyday scenario too. A teacher approaches the behavior analyst complaining about a student who consistently complains of a stomachache or a headache right before a challenging task, like reading out loud.
Right.
And the teacher just assumes the kid is faking it to escape the work.
Which is a very easy assumption for a frustrated educator to make, especially given the consistent timing, right? Like every time it's reading time, suddenly there's a stomachache.
Sure.
But the materials emphasize that the mandatory first step is consulting the school nurse to review the student's health history. An analyst cannot assume a behavior is serving an escape function until they have medically ruled out a legitimate physical ailment, like severe migraines or maybe real gastrointestinal issue.
The sources mention a conceptual tool used to filter these situations, called the dead man's test.
Oh, the dead man's test is a classic heuristic. The rule is incredibly simple. If a dead man can do it, it is not a behavior.
Give me an example of how that works in practice.
Okay, let's look at a person wearing glasses. A dead man can wear glasses if someone puts them on his face.
Okay, slightly morbid, but true.
Right. Therefore, wearing glasses is not a behavior. However, the act of picking up the glasses and placing them on your face, a dead man, cannot do that. That is an active behavior.
How does that apply to the medical rule-out, though?
Think about physiological responses. A dead man cannot complain about an earache, but a dead man can fall down or bleed or, be acted upon by gravity.
Right.
When a client is sweating profusely or experiencing a heart palpitation, those are physiological realities. We have to separate those biological responses from learned operant behaviors.
Operant behaviors being.
Operant behaviors are actions controlled by their consequences, like pressing a button to get an elevator to arrive. You can change an operant behavior by changing the consequences, but you absolutely cannot change a biological infection through consequences.
So you essentially have to pause your own specialized behavioral work to become a medical advocate. You dig into the files, looking for side effects of medications or missing diagnoses that everyone else just overlooked.
Yes, it requires a profound level of professional humility. The analyst has to look at a complex, screaming child and say, my tools are not the right tools for this moment. We need a doctor.
Wow. So, okay, we've used the records to rule out the medical issues. We've read the historical files so we aren't repeating past failures. Let's look at what happens when this paper trail leaves the clinic and goes to the insurance companies, because these records do a lot more than just establish clinical direction. They literally keep the lights on.
If we connect this to the bigger picture, meticulous record-keeping goes far beyond bureaucratic red tape. We are looking at specific ethics codes regarding accuracy in billing and documenting professional activity.
And the ethics workbook features some glaring violations here. Take case 46. You have a clinic that is billing an insurance company for active one-on-one ABA intervention, but the young clients being billed for are actually in a back room taking a nap.
Yeah, that's a huge issue. The insurance company is authorizing funds for medically necessary treatment. Now, napping is developmentally appropriate for a toddler, obviously, but it is not active behavioral intervention. Billing for sleep as if you were running discrete trial training is purely fraudulent.
Let's define discrete trial training for the listener really quick.
Sure, discrete trial training is a highly structured teaching method. The therapist breaks down a skill into tiny measurable steps, providing a specific prompt, waiting for the client's response, and then providing immediate feedback.
It's very hands-on.
Highly intensive, focused work. A child asleep on a cot is clearly not engaging in that process.
No, definitely not. And then case 47 presents a situation that feels much more emotionally complicated. A clinic is billing for ABA services, but they are actually providing respite care. For anyone unfamiliar, respite care is essentially professional babysitting that gives exhausted, overwhelmed parents a temporary break.
Right, and the professional in this scenario clearly had compassionate intentions. I mean, they saw a family on the brink of burnout, and they just wanted to provide relief. The problem is that the family's funding source was strictly authorized for ABA therapy, which focuses on skill acquisition and behavior reduction. It does not cover respite.
So they billed the insurance code for intensive therapy while simply watching the kids so the parents could sleep.
Exactly. And while the intent may have been deeply empathetic, the action is still fraudulent. A professional cannot misrepresent their services on invoices. The documentation must perfectly mirror the reality of the service provided in the room.
The sources note that these records must be retained for at least 7 years, and they have to be detailed enough for another professional to seamlessly take over the case at a moment's notice. But I have to ask, does the pressure to maintain all this audit-ready documentation ever distract from the actual human being sitting across the table? It just feels like an analyst could spend more time writing than helping.
Oh, that is a very common frustration, especially for newer professionals entering the field. But the guidelines frame documentation as an active component of helping the client. Think about unexpected life events. What if a behavior analyst suddenly moves away or falls ill? A new professional needs to step into that role immediately. If the records are vague or incomplete, that new analyst is starting from zero.
It's like a video game where someone forgot to hit save.
Yes,
The client has to replay the last 6 months of therapy just to get back to where they were.
that is a brilliant analogy. The documentation is a phase state. It protects the client from lost progress during those transitions. It also provides the objective data required to prove social validity.
Break down social validity for us.
Social validity asks a really fundamental question. Does this intervention actually matter to the client's everyday life?
Right.
Are we teaching skills that the client and their family genuinely value? Or are we just, changing behaviors for the sake of compliance? Without audit-ready data tracking the before and after, an analyst cannot prove that their intervention actually improved the client's quality of life. They would just be guessing.
That dramatically shifts the perspective. The paperwork isn't just a chore for the insurance company, it's a continuity mechanism for the client.
It creates a protective framework around the entire therapeutic process.
So bringing this wealth of information together, the golden rule of intake, the medical rule-outs, the ethical billing structures, how do our sources synthesize this for someone actually sitting down to take their board exams?
Well, there is a recurring, heavily emphasized theme across all the study guides,
The ultimate exam tip.
the ultimate tip. The materials are absolutely adamant about this concept. If a multiple-choice scenario asks for the first step in assessment, or what a professional should do at the outset of a case, the correct answer is almost invariably to conduct a records review.
So the analyst does not observe the client first. They do not write a preliminary plan first. They don't even interview the family first. They review the records.
They gather the existing data before introducing any new variables.
And the codes dictate that this isn't just passive reading either. There is a specific requirement, code F.8, that mandates synthesizing this data to prioritize goals that are socially significant, client-informed, and culturally responsive. How does reading a medical or educational file translate to cultural responsiveness?
The records provide vital context. Imagine an analyst reading an intake file and noticing that a family's cultural background places immense value on communal shared meals. Armed with that historical context, the analyst knows that writing a behavioral goal that involves, say, isolating the child to eat alone in a quiet room would be culturally inappropriate, and it would likely fail. The records dictate the boundaries of respect.
So what does this all mean for you, the listener? Even if you are completely outside the field of behavior analysis, how does this methodology apply to your everyday professional life?
It serves as a universal principle of problem solving. Consider a software engineer inheriting a massive legacy code base, or maybe a corporate manager taking over an underperforming project team.
Oh, no one enjoys inheriting someone else's messy legacy code.
No, it is universally dreaded. But if that engineer or manager skips their version of the records review, if they don't look at the historical data, the past failures, the environmental constraints that shape the current situation, they are absolutely guaranteed to repeat historical errors. They might implement a software patch or a management strategy that was already tried 3 years ago and completely discarded.
We all fall victim to the arrogance of the fresh start.
Yes, we do.
We want to walk into a new job or a new project and just be the hero who fixes the persistent problem with our brilliant new ideas. But true expertise seems to require the humility to read the old files first.
A fresh perspective has very little value if it is an uninformed perspective.
Which brings us back to you listening to this deep dive. Taking the time to review the records of any situation, whether you are starting a new job, navigating a new relationship, or analyzing a complex behavioral case, is the ultimate shortcut. It feels like slowing down, but it actually prevents disaster. It respects the history of the problem and sets a clear, ethical path forward.
It clears up the muddy waters of human behavior we discussed right at the beginning.
It fixes the diagnostic X-ray machine. So here is a final thought to leave you with today. We have explored extensively how past records, clinical notes, and medical files heavily dictate how professionals treat a client in the present day. Think about your own life and your own paper trail. What kind of data are you leaving behind in your daily interactions? If someone were to do a comprehensive records review on your work habits, your email chains, or your communication style right now, wait, no, let me rephrase that. Think about what story that file would tell the next person who steps into your shoes.
That is a deeply compelling question.
Something to mull over until next time. Thank you for joining us on The Deep Dive.